This is a presentation of a general examination of the musculoskeletal system for inflammatory conditions. It has been produced in conjunction with AMSEC, the Australian Musculoskeletal Education Collaboration. The examination of the musculoskeletal system can be adapted to serve multiple purposes. The aim of this video is to demonstrate a system of examining most of the joints for evidence of inflammatory or other arthritides in patients who are known to be symptomatic with joint pain. It is different to the Gow's examination, which is used as a general screening tool for musculoskeletal conditions in patients not otherwise known to have a musculoskeletal problem. Affected areas identified by history or during the screening examinations may be more comprehensively assessed with targeted regional joint examinations. Most patients with arthritis present with pain. Very often, the diagnosis is suggested by the history, and the aim of the musculoskeletal exam is to seek evidence to support one's provisional clinical diagnosis and to ascertain whether there are other physical signs to suggest an alternative diagnosis. Specifically, the purpose of the history and examination is to determine, amongst other things, the following features. In many cases, the goal is to determine whether the disorder is inflammatory. The cardinal features of inflammation are edema or swelling, warmth, erythema, pain or joint margin tenderness. These can lead to loss of function, including loss of range of motion. There are general courtesy issues that apply to any examination. You should ensure that the patient is comfortable, you request permission to proceed with the examination, and check verbal and non-verbal cues that the patient is experiencing any pain at rest or during the examination. The general principles of joint examination are to look, feel, and move. On general inspection of the patient, look specifically at their posture, body habitus, and skin, which may give some clues as to the underlying disorder. Examples of skin changes may include psoriatic plaques, rheumatoid nodules, or gouty tophi. Specific inspection of individual joints includes observation for erythema, swelling, and deformity. The goals of joint palpation include identification of joint tenderness, specifically at the joint margins, and joint soft tissue swelling or effusion. These findings may not be evident for deep joints such as the hip, so pain on passive movement can be used as a surrogate for tenderness. Assessment of active and passive range of motion gives an indication of loss of function. Although we mention look, feel, move, which is a very practical approach, there are no strict rules about the best sequence in which to examine each part of the body, so long as all the important elements are included and performed in an efficient manner. This presentation will now demonstrate a general examination of the musculoskeletal system for inflammatory conditions. With the patient standing, inspect from the front to assess the alignment and muscle bulk of the lower limbs and the posture of the feet. For example, you may see flattening of the longitudinal arch, which is termed pes planus, or deformity of the big toe away from the midline, known as hallux valgus. Ask the patient to turn and view them from behind to assess limb alignment and muscle bulk. Look for filling of the popliteal fossa by a Baker cyst, as well as alignment of the Achilles tendon, which may angle away from the midline. Then view the patient from the side to assess the spinal curves. The normal curves are the cervical lordosis, the thoracic kyphosis, and the lumbar lordosis. The lordoses may be abnormally flattened in some conditions and result in reduced range of motion. The thoracic kyphosis can similarly be increased, for example, due to multiple vertebral collapse fractures, as is commonly seen in osteoporosis. Ask the patient to walk across the room and back again while you observe the patient's gait for limp, symmetry of arm and leg movement, and ease of turning. Viewing the patient from behind, assess the straightness of the line of spinous processes. Curvature in the coronal plane is termed scoliosis. A range of inflammatory conditions may affect the spine, including the following. Assess spinal flexion by asking the patient to bend forward to try to touch their toes whilst keeping their knees straight. Assessment of forward flexion of the spine may make a scoliosis more obvious due to a fixed rib hump. The curvature, however, may disappear if it is due to muscle spasm. Assess spinal extension by asking the patient to lean back and slide their hands down the back of their legs as far as possible. By carefully supporting the patient, gentle overpressure can be applied. Lateral flexion can be assessed by asking the patient to run their left hand down the side of the left leg whilst keeping their back straight. Repeat to the right side. Rotation of the spine is best assessed with the pelvis fixed, so ask the patient to put their hands on their hips and turn to the left and then to the right. The Schober's test is used to assess forward flexion occurring in the lumbar spine rather than at the hips. Identify the level of the posterior superior iliac spines, or PSIS. After informing the patient and using a tape measure, mark the skin 5 cm below and 10 cm above a line at the level of the PSIS. Ask the patient to bend forward again and measure the distance between the two marks. It should have increased by at least 5 cm. Measure the chest expansion at the level of the nipples. Ask the patient to take a deep breath in, then to breathe out all the way, then to take another deep breath in. Measure the distance between full expiration and full inspiration. This can be reduced in inflammatory arthropathies involving the lumbar spine and the costochondral and costovertebral junctions. Next, examine the cervical spine. To assess forward flexion, ask the patient to put their chin on their chest. You can gently apply overpressure at the extremes of range to assess passive movements. To assess extension, ask the patient to look up to the ceiling and extend the head back as far as possible. Again, you can gently apply overpressure. For lateral flexion, ask the patient to put their left ear on the left shoulder whilst keeping their nose facing forward, and then the right ear on the right shoulder. Apply gentle overpressure after each. For cervical rotation, ask the patient to turn the head to the left as far as possible and then to the right. Similarly, apply gentle overpressure after each side. Next, examine the shoulders. Look for swelling in the anterior fossa, which would usually indicate a large subacromial bursa effusion. Inspect the bony landmarks, including the acromioclavicular joint, which may be swollen or dislocated. Examples of inflammatory conditions affecting the shoulder and their manifestations include the following. Palpate the anterior margin of the glenohumeral joint for tenderness and swelling. The edges of the acromion, the subacromial space, and the AC joint. Then posteriorly. To assess shoulder forward flexion range of motion, ask the patient to keep their elbows straight and to raise their arms forwards as far as possible. For shoulder abduction, keep their elbows straight, lifting them out to the side as far as possible. For external rotation, rotate the forearms outwards with the elbows bent to 90 degrees and tucked into the side. And for internal rotation, moving the hand up as far as possible behind the back. Note and compare the highest spinal levels that are reached. While the patient is standing, assess their muscle strength by asking the patient to abduct their shoulders with their elbows bent at 90 degrees and keep the arms up against increasing resistance from the examiner. Abduction may cause a painful arc, with pain occurring whilst lifting the arm, followed by relief of the pain in full abduction, and return of the pain again as the arm moves through the same position of the arc during adduction. Special tests can be performed for impingement of the supraspinatus tendon under the coracoacromial ligament. This includes active movement of the arm, again through that same arc, whilst keeping the palm facing up towards the ceiling. This externally rotated position of the shoulder reduces the pain if it is due to impingement. To examine for any evidence of weakness in the lower limbs, ask the patient to squat down to the floor and, without touching the floor, rise from a squat. Stand to the side of the patient, ready to give support if needed. The finding of proximal muscle weakness suggests an inflammatory myopathy, which can occur in some autoimmune disorders. If found, a full neurological examination would be necessary. Now examine the feet. With the patient lying on the bed, inspect the feet from the end of the bed where it is easier to make an assessment of symmetry. Look for colour change, erythema, and swelling in joints or in the extensor tendons of the feet. Examine the nails for pitting or onycholysis, which may be associated with psoriatic arthritis. Also look for joint deformity, such as clawing. Don't forget to examine the soles of the feet. Callosities under the metatarsophalangeal joint suggest abnormal weight bearing on walking or subluxation of the MTP joints. Palpate the joint margins of each MTP joint individually. Individual digits can also be inspected and palpated. The margins of the tarsometatarsal joints, which are joints of the midfoot, are difficult to define individually for tenderness, so pain on movement is used as a surrogate for joint tenderness. Fix the ankle proximally while twisting the forefoot. Again, the subtalar or talocalcaneal joint is difficult to palpate, so pain on movement is sought. The ankle is fixed in the neutral position at 90 degrees and the heel is inverted and everted. This can be done with either the knee extended or flexed, e.g. in the prone position. The hinge joint of the ankle or the tibiotalar joint is examined next. Look for swelling, for example, filling in of the fossae behind the lateral and medial malleoli. Then palpate the ankle along the anterior joint line, the extensor tendon sheaths, and the peroneal sheaths for evidence of tenderness and swelling. Passive and active range of motion should be assessed by asking the patient to bend the ankle, then point their toes, whilst you apply overpressure to assess passive range. The entheses around the foot and ankle should be palpated for tenderness and swelling. Especially note the Achilles tendon insertion into the calcaneum and the insertion of the plantar fascia, including the medial slip of the fascia, as inflammation at these sites is a feature of the spondyloarthritis. Examples of foot and ankle manifestations of arthritic conditions are listed here. Inspection of the knees should include the whole leg in order to assess for alignment, e.g. genuvarum or valgum. Look for muscle wasting, particularly the quadriceps muscles, which become atrophied due to pain or joint inflammation. Look for swelling due to an effusion, which may be seen as filling of the fossa, either side of the knee and the suprapatellar pouch. And also look for bursal swelling, such as in the prepatellar tendon region. The joint margins are palpated for tenderness, both medially and laterally. Painful and reduced motion of the patella on the posterior femoral condyles, often with crepitus, suggests osteoarthritis. Palpate the knee posteriorly for popliteal swelling, e.g. Baker's cyst, which is best seen on standing. Special tests are used to detect effusions. Moderate to large effusions are evident using the patella tap. Place your left hand on the suprapatellar pouch to empty it of fluid, and then press on the patella to find excessive movement in the intercondylar groove. The bulge sign identifies smaller volumes of fluid. Milk the synovial fluid into the suprapatellar pouch, which is in continuity with the joint space. Maintain the pressure to close off the return route. Use the other hand to push the fluid from the lateral side back into the joint space. Look for evidence of filling or bulging in the medial fossa. Movement is assessed as a combination of active plus applied force or overpressure to assess the full range of passive movement at the extremes of the range. To assess flexion, ask the patient to bend the knee, bringing the heel to the buttock. If the heel doesn't fully reach the buttock, gentle overpressure can be applied to assess passive flexion range. Keep your hand on the knee to also assess for crepitus. To assess active extension, place your hands under the knees and ask the patient to push the backs of the knees into your hands. To assess for additional passive extension, now lift the foot. It is usual, at least in young people, for there to be a few degrees of extension beyond neutral, so that loss of even a few degrees of extension in one knee compared to the contralateral knee can indicate an abnormality or even a fixed flexion deformity. Examples of knee manifestations of arthritic conditions are listed here. The hip joint is difficult to assess for swelling or tenderness being so deep, but wasting of hip flexors or gluteal muscles may indicate significant arthritis. Palpate the ASIS, that is anterior superior iliac spine, deepen the groin, and also the greater trochanter for tenderness. Ideally, when assessing hip range of motion, the pelvis should be stabilised by placing the hand on the contralateral iliac crest. Test active motion by asking the patient to bring the knee up to the chest, then gently push the leg up further to assess passive flexion. Whilst in this position, you can assess extension of the other hip. If there is a fixed flexion deformity at this joint, the thigh will lift off of the bed as the hip is unable to be fully extended. Assess rotation with the hip flexed to 90 degrees. The lower leg becomes an indicator of the degrees of rotation. The Faber test, that is, flexion in abduction and external rotation, is a good screen for range of motion as well as for sacroiliac joint pain. On examination of the hands, inspect the joints for swelling and deformity. Swelling of the DIP joints can be bony due to osteoarthritis, where these are referred to as Heberden's nodes, or due to soft tissue swellings, e.g. in psoriatic arthritis. They tend not to be infected in rheumatoid arthritis. Swelling of the PIP joints is common in many forms of inflammatory arthritis as well as osteoarthritis, when the changes are referred to as Bouchard's nodes. The MCP joints, especially the second and third, are typically affected in rheumatoid arthritis, but tend to be spared in osteoarthritis. Swelling of the extensor tendon sheaths due to extensor tenosynovitis is not uncommon in rheumatoid arthritis, as is swelling of the wrist joint. Swelling of the whole digit or sausage digit due to dactylitis is characteristic of spondyloarthritis. Typical deformities of rheumatoid arthritis include swan neck and boutonniere's deformities of the fingers and Z deformities of the thumb. The dinner fork deformity of rheumatoid arthritis is due to ulnar deviation at the MCP joints combined with radial deviation and volar subluxation at the wrist. The first or thumb carpometacarpal joint affected by osteoarthritis has a characteristic squared-off appearance. Important extra-articular features evident on inspection include nail changes such as pitting, onycholysis, subungual hyperkeratosis of psoriasis, or changes that occur in autoimmune diseases, e.g. dilated nail fold capillaries or hemorrhages, seen with or without magnification. There are other important features of autoimmune diseases, particularly systemic sclerosis, which should be sought, including the following. Inspect the nails for changes such as pitting onychocolysis or subungual hyperkeratosis seen in psoriasis, or changes that occur in autoimmune diseases such as dilated nail fold capillaries or hemorrhages. Inspect the palms for muscle wasting and palmar erythema as seen in rheumatoid arthritis and other medical conditions. Dupuytren's contractures are usually seen also affecting the ulnar side. Next, palpate the joints for swelling and joint margin tenderness. Palpate the joints in two planes and block for fluid. Assess the DIP joints, the PIP joints, and the MCP joints. Check for full passiflexion, assess swelling, and open up the joint margin for palpation of tenderness. Next, assess the wrists. Assess joint range of motion by asking the patient first to make a fist and then to fully extend and spread the fingers. Then check individual joints passively for restriction by flexing each digit while at the same time palpating the flexor tendon sheaths with your thumb for crepitus or click. This may explain any reduced range of motion. To check for range of motion of the wrist, ask the patient to put together their palms and then the backs of their hands. Examples of hand and wrist manifestations of arthritic conditions are listed here. Next, inspect and palpate the elbow in 90 degrees of flexion. Look for rheumatoid nodules, usually over the radial border of the olecranon, psoriatic plaques, ulceration, bursal swellings, gouty tophi over the olecranon, or synovial swelling over joint margins, suggesting effusion. Now palpate around the olecranon and the radial head for swelling and tenderness. Ask the patient to bend their elbows, then apply a little overpressure to assess passive range. Ask the patient to extend their arms, then apply pressure for passive extension, comparing both elbows. Full extension makes significant interarticular disease unlikely. Ask the patient to bend their elbows to 90 degrees with the elbows tucked into their sides, then rotate the palms to the ceiling to test supination, and then down to the floor for pronation. Gentle overpressure can be applied. Examine the sternoclavicular joint, the manubriosternal joint, and the costochondral osteocartilaginous junctions for swelling and tenderness. Now assess the temporomandibular joints. Inspect looking for any swelling or malalignment. Next, palpate for swelling and tenderness. Assess range of motion by asking the patient to fully open and then close the mouth. Remember that many arthritides are multi-system disorders. The musculoskeletal examination should therefore be performed as part of a general physical examination to identify any extra-articular features. This video has been produced as part of the AMSEC project. Any comments or suggestions for improvement are welcome and can be forwarded via www.amsec.org.au.